Well, next, with a nice intro by Dr. Diodor there, we're very pleased to have Denis Poddubnyy from the Charité in Berlin talking about the evaluation of the sacroiliac joint. Denis?
Hello, dear colleagues, dear friends. My name is Denis Poddubnyy. I'm a rheumatologist from Berlin, Germany, and today I'm going to talk about evaluation of the sacroiliac joints in the context of the diagnosis of differential diagnosis of axial spondyloarthritis. Here you see my disclosures. I believe they won't be really relevant for the content of today's talk. If we talk about axial spondyloarthritis, not only the nomenclature, the name of the disease has changed, so we prefer to say axial spondyloarthritis instead of ankylosing spondylitis or Bechdrev's disease, but also the patient profile, the patient face has changed. This is a typical picture as we saw it some decades ago, and nowadays our patients, if they are diagnosed early, if they are treated early, they do not have major limitations in spinal mobility, and this is only possible with early diagnosis and early initiation of anti-inflammatory treatment. This is, by the way, a real patient of mine who has been diagnosed with axial spondyloarthritis about 15 years ago, and you see an excellent outcome after such a long time period. In the context of axial spondyloarthritis, there are several frequently asked questions, and one of those questions is it possible to diagnose axial spondyloarthritis without imaging? The short answer is yes, it is possible, but you need to keep in mind that such a clinically based diagnosis would be always less certain, less reliable than the diagnosis which is based also on imaging findings. Why is it so? Very easy, because imaging is nowadays the only possibility to confirm the presence of inflammatory affection of the axial skeleton, and there are no diagnostic tests, clinical tests, which would help us to differentiate between mechanically induced back pain and back pain caused by inflammation. Let me illustrate this by this patient example. So this patient, male patient, 53 years old, has been referred to a rheumatologist by an ophthalmologist because of the presence of intermittent inflammatory back pain for already about 20 years and presence of acute anterior uveitis with last flare about 2 months ago and the previous episode about 10 years ago. There were no other spondyloarthritis manifestations, and CHLEB27 was positive, CRP was currently normal. So if you look at this patient profile, you would say, in this case, spondyloarthritis might be indeed a reason of back pain, but we are not sure in this case because we haven't seen inflammatory affection of the axial skeleton yet. And if you apply the classification criteria, others classification criteria for axial spondyloarthritis on this case, that would be, by the way, completely wrong because we do not have a definite diagnosis here, you would realize very quickly that the classification criteria are fulfilled because we have here a patient with chronic back pain that started before 45 years of age, who is B27 positive and has inflammatory back pain and acute anterior uveitis. But this would be a wrong approach, and we need to make the diagnosis first before we can apply this classification criteria set. And this is exactly the place where imaging would play a major role in increasing the diagnostic confidence in a patient with suspicion of axial spondyloarthritis. We still leave with this set of recommendations for imaging in patients with suspected spondyloarthritis, and this still recommended to perform an X-ray of sacroiliac joints first as a first imaging method if spondyloarthritis is suspected. This has been done in our case And what you see here, you see a so-called Ferguson view of the pelvis. This is a good method to depict also the upper portion of the sacroiliac joint, because in the conventional AP view of the pelvis, this part is quite frequently obscured because of natural overlap due to complex configuration of the joints. And what you see here, left side is fairly normal, and on the right side there is a pathological finding. Here you see some sclerosis, and if you look precisely, you don't really see a joint space here very well. So it will be a question, what is the grade? Is it sacroiliitis? And if yes, well, what would be the grade? At the same time, you see that the lower portion of the joint looks completely normal. So it raises a suspicion that might be a finding not related to spondyloarthritis. And this is exactly the point where we need advanced imaging. There is also another question whether we should always perform X-rays first. And the answer is that we get more and more data suggesting that X-rays are not really helpful in making the diagnosis of axial spondyloarthritis. This is one of the recent publications dealing with that problem. What we did here, we selected 163 patients with complete set of images, and complete set means that we had from all patients an X-ray, an MRI, and CT of sacroiliac joints, and all these images were divided into 5 campaigns, reading campaigns done separately. So we scored first all X-rays, then all MRIs, then CT, then a combination of MRI with X-rays, and finally MRI with CTs. And the outcome of each of those readings was the presence or absence of imaging findings compatible with spondyloarthritis. The gold standard was the diagnosis of SPA done by a physician. Here you see the major results. Here you see the sensitivity and the specificity of the finding, or a proportion of false positive findings. If you look at X-rays, then you realize that this method is neither really sensitive, only 66%, nor very specific, with a specificity of about 70%. If you look at the imaging method with the highest sensitivity, it will be MRI. And this is clearly related to the fact that MRI is able to detect not only structural changes, but also active inflammatory changes. So with MRI, we can capture very early disease stage. If you are looking for imaging method with the highest specificity, it would be certainly CT. And this is related to the fact that structural changes, definite structural changes such as erosions, they do have high specificity, probably even higher specificity than just bone marrow edema. So based on this, you can decide which imaging method should be preferred. So if the budget, if resources are not limited, you are able to perform advanced imaging right away, then I would recommend to start with MRI, and only in an uncertain situation one could go for a CT. Otherwise, if resources are limited, then X-ray would be still the first imaging method, followed by MRI. And this is also reflected by the current EASA's EULAR imaging recommendations, and MRI is here the imaging method that is recommended after X-rays. One of the frequently asked questions is which MRI sequences should be performed in the case of suspicion of axial spondyloarthritis. And I need to say the quality of imaging is really important to make a reliable conclusion out of this. And ideally, you need 3 sequences to depict active inflammatory and structural changes. Which are those sequences? There is a clear recommendation set presented last year at EULA. For the first time, it is in line with previous recommendations, and we're talking about 2 sequences for the depiction of active inflammatory changes and 2 sequences depicting structural changes. You might realize that, in fact, these are 3 sequences, and we perform 1 sequence. This is STIR or TERM or T2 weighted sequence with fat suppression in 2 planes or projection or orientations in semicoronal and semi-axial. And this is done to be able to depict active inflammatory changes both in cartilaginous portion of the joint and in the posterior ligamentous portion of the joint. And for the depiction of structural changes, we have T1 weighted sequence, and the modern sequence, it could be a 3D gradient echo sequence, also called WIPE sequence. So here you see the configuration of the sacroiliac joints and those planes or orientation. This is a semi-coronal plane, and this is a semi-axial plane. Here you see examples of those images, and here you can be sure that with those images you can capture the entire spectrum of active inflammatory and structural changes. This is inflammation-sensitive sequences, STIR semicoronal and STIR semi-axial, and these are 2 structural changes sensitive sequences, T1 weighted sequence and so-called WIPE sequence or 3D gradient echo sequence. The next question would be, what do I need to see on MRI to be sure that this is axial spondyloarthritis? For classification purposes, bone marrow edema is important. But for the diagnosis, for reliable diagnosis, you need to consider bone marrow edema in the context of structural changes, which do have big, maybe even bigger importance than just active inflammation. There is a definition of active sacroiliitis on MRI for the classification of axial spondyloarthritis, which is developed for the classification purposes only. And what you see here in the box number 1, the required is the presence of bone marrow edema, which is clearly present, located in a typical anatomical area, and this should be highly suggestive of spondyloarthritis. What does it mean, highly suggestive of spondyloarthritis? It should be large, it should be big, it should be located in a typical anatomical region, but then also structural changes such as erosions, fatty lesions, backfill sign, they might help you to make a conclusion that this bone marrow edema is really suggestive of spondyloarthritis and not related to mechanical stress, for instance. So let's have a look at the images of our patient. Here you see all 3 sequences as I presented. So here you have STIR, so inflammation sensitive sequence. So please have a look at this. Look for potential inflammation here. Then we have T1 weighted sequence. There we would be looking for structural changes like erosions, fat, backfill, and then we have WIPE sequence, 3D gradient echo sequence, which is great to depict erosive changes in the sacroiliac joints because of great contrast between cartilage and the bone. And here at this time point, I would like to ask you a polling question. What do you think? You remember this is a male patient with a history of uveitis with intermittent inflammatory back pain for several years, B27 positive. So do you think this is axial SPA now? And you have the following options. So axial spondyloarthritis, maybe you think this is just an osteoarthritis of sacroiliac joints. Maybe it's for you degenerative spinal disease, spondylodiscitis, or other diagnosis or the diagnosis is unclear. So please vote now, and in a few seconds I will show you the correct answer. So let's have a precise look at MRI images. So first, here in a stir sequence, we see that sacroiliac joints, they both look quite good. There is no bone marrow edema in sacroiliac joints, but you see some bone marrow edema in the vertebral body here of the fifth lumbar vertebral body. So what is this? You will see it on the following slide, and here you see that there are no structural changes in sacroiliac joints, at least no SPA typical structural changes, but you have some capsule ossification here, and this huge osteophyte was responsible for a picture of ankylosis or pseudo-ankylosis on the X-ray. But this has nothing to do with ankylosis as a part of axial spondyloarthritis. This is a common degenerative finding. And then you have a degenerated disc here with some fatty metaplegia of the bone marrow, so-called Modic 2 lesion, so old lesion. You saw also in stir that there was a little bit of inflammation here around this. And this is the most likely explanation of intermittent symptoms of this patient over the past years, and not spondyloarthritis. Just to be sure, let's have a look at wipe. We see here again very nicely this huge osteophyte capsule ossification. We see degenerated disc, and nothing compatible with spondyloarthritis, especially no erosive damage. So in this case, the diagnosis would be degenerated disc disease, no spondyloarthritis, and if you answered osteoarthritis of sacroiliac joints, this would also be correct, because we have also osteoarthritis findings in the right sacroiliac joint. So let's have a look at the second case. This is a male patient, 55 years old, with the same patient profile, and I saw those both patients within 2 weeks in the outpatient setting. He has also been referred to us by an ophthalmologist because of the presence of back pain on the background of uveitis. B27 was also positive. CRP was normal. So let's have a look at MRI. In this case, again, you have a stir picture on the left side and T1 weighted MRI on the right hand side, and you might expect that I will be asking the same question again. Do you think that in this case the diagnosis could be axial spondyloarthritis or something else? So have a closer look at the images, and then please try to answer the question, which diagnosis would you make in this case? Axial SPA, osteoarthritis, infectious sacroiliitis, osteitis condensans, ELI, or other diagnosis, or the situation is rather unclear. So again, a few seconds to answer this question, and then there will be an answer to it. So in this case, we see on stir image a little bit of bone marrow edema. We are here in the rather posterior part of the joint, so we see here a little bit of bone marrow edema, a little bit here, and close to the capsule. I need to say that all these areas affected by bone marrow edema right now might be also manifestation of mechanical stress, an enthesial part of the joint and the capsule. So this is not very convincing, and it is a big question now. Is it bone marrow edema related to spondyloarthritis or not? And as we discussed previously, in such a situation, it is extremely important to look at T1 weighted sequence to see are there structural changes. And if we look at T1, we see that they are there. So we have fatty metaplasia, we have erosions. You see that joint margin is clearly abnormal. You have also backfills, so repaired erosions, and you have also a bone barred, so a step just before the ankylosis. So finally, in this case, the interpretation of this tiny bone marrow edema would be absolutely clear. This is a manifestation of axial spondyloarthritis, and the diagnosis could be made in this case. The problem is, however, that things are not always what they seem, and in the daily clinical practice, it is extremely important to identify what is true bone marrow edema associated with spondyloarthritis and what is bone marrow edema related to mechanical stress. There's been several publications, several attempts to look at the prevalence of mechanically induced bone marrow edema, and this is work which evaluated recreational runners and elite ice hockey players. And here we had really a big prevalence of bone marrow edema from 30 to 40% in apparently healthy people without any back pain complaints. And this study was also important to demonstrate the anatomical areas which are affected by mechanical stress in these athletes. And we learned from this study that caudal part of the joint and very anterior part of the joint, they are affected by mechanical stress. So if you see bone marrow edema or sclerosis in this or this area, there should be a suspicion that these changes might be related to mechanical stress and not to inflammatory disease. There were several other works which demonstrated that indeed bone marrow edema is quite prevalent in healthy subjects, in people with chronic back pain, in runners, and in postpartum women. One of the most recent works was dealing with healthy young people from a population-based cohort, and this study has identified that bone marrow edema was present in about 17% of healthy people with MRI of sacroiliac joints. So that means that the specificity of bone marrow edema, at least based on the results of this cohort, would be about 83%. And we need to learn how to identify bone marrow edema that is really related to inflammation. So the most important things are the localization of bone marrow edema. So if it is localized in the area affected by mechanical stress, such as very anterior portion of the joint, it is not specific. And also, if you don't see any signs of structural damage, especially in patients presenting to you after 2, 3, 4 years after symptom onset, back pain onset, it would be highly suspicious that there is no inflammatory disease behind this. What could help us in imaging interpretation? We are working on implementation of artificial intelligence method like deep learning to detect active inflammatory and structural changes associated with spondyloarthritis. And the first study was quite successful. It showed that the machine, the computer, is able to detect active inflammatory and structural changes compatible with spondyloarthritis, very close to the level, to the judgments done by the experts. So this is work in progress, and I do believe that human intelligence is even more important than artificial intelligence, and that is why we're doing many educational efforts to improve that differentiation between inflammatory and all other problems in the spine. And what you see here, it's ASA's online case library. This is an educational ongoing project where you can see quite a number of examples of patients presenting with suspicion of spondyloarthritis with and without a final diagnosis of axial SPA, where there is quite detailed explanation of clinical picture, lab findings, and also imaging findings. I come to my take-home messages, and the diagnostic workup in patients with suspicion of axial spondyloarthritis normally includes proper use and interpretation of imaging. MRI of sacroiliac joints is a method of objective detection of active inflammatory, post-inflammatory changes, and is very important, therefore, in the early diagnosis and differential diagnosis of axial SPA. It is very important to stress that bone marrow edema in sacroiliac joints might be related to mechanical issues, and the presence of bone marrow edema should always be interpreted in the context of anatomical localization and presence of structural changes, and of course in the clinical context. And finally, if we're talking about technical aspects, so T2 weighted fat saturated sequence such as STIR or TERM and T wide weighted sequence are normally sufficient. No gadolinium is needed, and the WIPE sequence or another 3D gradient sequence is included now as an additional third very helpful MRI sequence to make the right diagnosis in our patients. That's it from my side. Thank you very much for your attention.